Good day, all. Welcome to this episode of the System Podcast. Today, we'll be continuing with our obstetrics and gynecology revision series, and we'll be talking about the management of PROM, preterm rupture of membrane. And we'll use a VNIAC here to qualify our explanation of the management of PROM. The VNIAC is a 34-year-old gravida 2 para 1 plus 0. Gravidity simply means the total amount of pregnancy a woman have had, irrespective of the outcome, and parity means the amount of pregnancy which she have taken beyond the age of viability, that is 28 weeks in our setting. And 1 plus 0 is just trying to tell you that 1 is being delivered and none is lost. Who had a past history of premature delivery. When we say premature delivery, we are just trying to say that she delivered before term. And now presents with draining of liquor amni at 32 weeks gestation. Liquor amni, also known as liquor, this is the fluid which drips out from the vagina when it's time for delivery, maybe preterm, as in this case. But this fluid is trying to tell us that there's a rupture of membrane and the baby is trying to come out. What will you do to confirm the diagnosis of this patient? The first part of the question is just trying to tell us how will you diagnose the patient. So let's go into the first straight. Now, to confirm the diagnosis of this patient, there's a stepwise process that we have to follow. Now, confirming the diagnosis of any disease, there's a confirmative test. It's either you confirm via history, physical examination, or investigation. Now, in this case, which we are dealing with, preterm rupture of membrane, the steps, the way we can confirm our diagnosis, following this 5 steps. Now, the first is history and physical examination. And for the history, we'll ask the patient the onset, the amount, and the color of the fluid. And we perform a sterile speculum examination to visually confirm pooling of amniotic fluid in the vaginal vault. Now, you don't just get it from her word that she's having liquor or fluid coming out of her vagina. You want to see by yourself, and speculum is just a fancy word of saying the tool which you put into the vagina to visualize the cervix and so on, and to visualize inside the vagina. So you want to see that there is liquor amni coming out. 2, the nitrazine test. The nitrazine paper is a paper which you use to test the pH. Now, the pH of amniotic fluid, which is different from the pH of the fluid coming out of the vagina. pH of the vaginal fluid is acidic, while the amniotic fluid is basic. So the pH of the amniotic fluid is 6.5 and above. Now, if you use your nitrazine paper and dip it in it, it turns blue, which is just trying to tell you that this is amniotic fluid. And that's another way to also confirm. Next, you want to also do the fanning test. Now, fanning test, from the word fan plant is just a plant which have its leaf is fan-like, just like the fan, ceiling fan, And when you collect a sample of the fluid and allow it to air dry on a glass slide under a microscope, amniotic fluid forms a characteristic fan-like pattern, which is different from normal vaginal fluid. Normal vaginal fluid will not form that. That's another way to confirm. Another way to confirm is the ultrasound. If you see the way we go for a less invasive or the less money needing, the one that does not require payment to the ones that require payment of money. So ultrasound, now you assess the amniotic fluid index. Now, in assessing the amniotic fluid index, you are trying to evaluate the volume of amniotic fluid and confirm the diagnosis. So it's a process which we use an ultrasound to do, where you do an imaginary line on the abdomen, where the midpoint of the imaginary line should be the navel, and you do a vertical and horizontal line and try to check the index level of the amniotic fluid in those different quadrants that you have gotten based on your imaginary line. Now, the next thing is the amnisure or ROM plus test. So this one is not kind of routinely done in our setting, but I'll still talk about it. These are commercially available tests that detect placental alpha microglobulin 1 or insulin-like growth factor binding protein 1, which are specific to amniotic fluid. So this is another way to confirm. So in the case whereby we have done this and we have been able to confirm that we are dealing with preterm rupture of membrane, so the next thing we want to do is we want to administer some medication. And from the question given to us here, because it's a focused question, so it's a focused VINIAC, and the question is trying to say, what drugs will you give? Now, the drugs you are going to obviously give, this is logical. You are having a patient who has a preterm rupture of membrane. The aim of obstetrics and gynecology is to have safe mother and safe child. So here now, you have to think logically. The first thing you want to do is to start giving corticosteroids, specifically dexamethasone. You want to administer dexamethasone to promote fetal lung maturity and reduce the risk of respiratory distress syndrome, intravascular hemorrhage, and necrotizing enterocolitis, because there's high chance that this child will be delivered before term. So you want to do this so that you have quick lung maturity and the other things that I have said earlier. The next thing that is, you want to give antibiotics. Why do you want to give antibiotics? Because you want to prevent maternal infection, because the rupture of the membrane is giving a pathway for the woman to easily contact chorioamnionitis, which is very deadly, which can cause the woman to die by having septic shock. Now, you start prophylactic antibiotics to prevent infection and prolong latency. A common regimen include a combination of ampicillin and erythromycin for the first 48 hours, followed by amoxicillin and erythromycin for an additional 5 days. The next thing you do is you want to try as much as possible to inhibit contraction. So in that case, you will give tocolytics. This may be used short term to delay delivery for 48 hours to allow corticosteroid to take effect. Although their use is kind of controversial in PROM, but in our stage as students, we don't want to go into controversy. All we know is that you give tocolytic to reduce the possibility or inhibit the possibility of contraction. And the next very important thing that you have to do is magnesium sulfate. You want to give magnesium sulfate. If the delivery is imminent before 34 weeks, you have to administer it for you to be able to get fetal neuroprotection and reduce risk of cerebral palsy, because if you don't have the fetal neuroprotection, you can have a risk of cerebral palsy, which we know is a very great morbidity which, like, the child will be unproductive throughout his life. The next thing which the question is trying to test from us is, what are the features of chorioamnionitis you will look for in this woman? You know, the risk which this woman is kind of exposed to is chorioamnionitis. So what is the features of the chorioamnionitis you want to look for? Maternal fever. Maternal fever is axillary temperature above 38 degrees Celsius or higher. Then maternal tachycardia, heart rate which is more than 100 beats per minute. Fetal tachycardia, you can use the CTG to check the fetal heart rate, which should be below 160 beats per minute. In the case which is exceeding 160 beats per minute, then there is a possible risk of chorioamnionitis, fetal tachycardia. Sorry, we've said fetal tachycardia, uterine tenderness. Tenderness just means pain by compression. When you compress the uterus and the woman feels pain, then you are possibly dealing with chorioamnionitis, foul-smelling amniotic fluid, a strong odor from the vaginal discharge. This is trying to tell you that there is possible chorioamnionitis because the presence of the organism will cause the amniotic fluid to be purulent in nature. Then leukocytosis, this is the lab test you do to check the amount of leukocytes. When there's leukocytosis, this is telling us that there's possible infection which is happening, elevation of white blood cell. Now, the next thing which the question is trying to get from us, they are trying to know, when will you plan to deliver this patient? That is when delivery is kind of imminent. When will you think that, what will you see to deliver this patient? Timing of delivery in the context of preterm rupture of membrane at 32 weeks involve balancing the risk of prematurity against the risk of infection and other complications. So this is what we are trying to weigh, the two things we are trying to look at before we will think of delivery. Now, the first thing is expectant management. If there are no signs of infection, fetal distress, or other complications, manage expectantly to prolong the pregnancy, administering corticosteroids and antibiotic. So that's what we should do if everything is okay. So we just continue giving our corticosteroids and antibiotics and wait expectantly to term before we deliver the baby. But in the other indications for delivery, is the first thing is chorioamnionitis. You immediately deliver irrespective of the gestational age in this context of chorioamnionitis, because here the risk now has turned to the mother. Now, in the case whereby you are at the risk of losing the mother, you rather lose the child than you lose the mother, because the mother can always get pregnant again and deliver another child. But you said you want to risk and you want to become a superhero to save the child, you end up losing the two at the end of the day. So fetal distress, non-reassuring fetal heart rate patterns or biophysical profile. When there's no reassuring heart rate, you try to deliver for the sake of the child to see if you can help the child in the neonatal unit, how they can be able to put the child there and see if he can develop in the incubator. Because at that stage, it's trying to tell us that the child can no longer survive in the womb of the mother. Maternal complications such as significant bleeding or severe preeclampsia. When there's severe preeclampsia in our setting, it's just delivery, irrespective of the gestational age of the baby. Preterm labor, if labor cannot be halted with tocolytics, you have no choice than to deliver the child. So ideally, we aim for delivery closer to 34 weeks because at that time, most of the organs and the lungs and everything have matured. So as this significantly reduces neonatal morbidity and mortality compared to earlier gestations, if the patient reaches 34 weeks without complication, elective delivery may be considered. So I'd like to thank you for tuning in to this episode. I suggest you like, subscribe, and share to your friends because this helps the algorithm of YouTube to push it to more people. Thank you very much. We'll meet in the next one.